thank you, Corey. It's a pleasure to take on that challenge. So as Corey said, the standard of care is platinum etoposide. I'm not going to spend any time discussing that. If anyone wants to discuss it, I'm happy to. But I thought I'd actually talk about something more interesting. So you've just heard two talks about lung adenocarcinoma and the subtypes and the progress that's been made by defining oncogenic mutations that are drivers of subsets of the disease. And we really think about adenocarcinoma now not as one disease, but as these multiple diseases really defined by the oncogenic driver, which in most cases are kinases. And that's really led to the sort of progress against this disease that you've seen, really striking results. I would contrast that with what we know about the mutational spectrum in small cell lung cancer. Small cell lung cancer is largely a disease that's driven by actually loss of function mutations. The signature of this disease is actually concomitant loss of two key tumor suppressor genes, TP53 and RB1. Almost all small cell lung cancer has deficiencies in these two genes, but because they're loss of function, they do not immediately produce a target that one can develop a drug to, and I think that has limited our ability to think about targets in this disease and subsets of disease. I do think that's changing, but that's been a component of the problem in small cell lung cancer. The first topic I'm going to touch on is immunotherapy for small cell lung cancer. I think this is actually perhaps the most exciting current clinical data in small cell lung cancer, and this has been similar to immunotherapy across other disease types. You're going to hear a session on that, I think, immediately following this one. But I'll focus on the current studies in small cell, starting out actually with a disappointment, right? So this was a large phase 3 trial looking at the CTLA-4 directed agent ipilimumab with chemotherapy versus standard of care chemotherapy in the first-line setting. Clearly, no separation in these curves, a major disappointment. So targeting CTLA-4 in the absence of targeting PD-1 in this disease, clearly not sufficiently active to warrant further development. However, in this study, which is the Checkmate 032 study, looking at Nivolamab, a PD-1 checkpoint inhibitor, together with ipilimumab or as a single agent, you can see two things, I think, that are interesting. One is that both of these curves have tails on them. That is, not all patients are demonstrating evidence of disease recurrence, progression, or death. And secondly, it looks like small numbers, but it looks like the ipilimumab may actually be adding something to Nivolamab here, improving the response rate and perhaps improving long-term disease control. Pembrolizumab also has activity in this context, so both Nivolamab and pembrolizumab are active agents. This was the Keynote 028 study, sorry. This was actually selected for patients whose tumors express PD-L1, which is actually a small subset of small cell lung cancer. Most of these tumors do not express PD-L1. And I would say the data here are similar to what we're seeing with Nivolamab, and there's no studies comparing these agents. Interestingly, PD-L1 does not tend to be expressed in small cell lung cancer at high levels, and in the data that we have to date, PD-L1 expression does not appear to be a predictor of benefit from PD-1 checkpoint inhibition. So this is, again, from the Checkmate 032 study, and the dark bars here are PD-L1 negative tumors, and you can see that the responses are seen regardless of PD-L1 status, and certainly include patients who are truly PD-L1 negative, both for Nivolamab and for the combination of Nivo with Ipi. This year at World Lung, there were some interesting data that were presented looking at tumor mutation burden as a predictor of benefit from these drugs. Again, PD-L1 is not a predictor. What about tumor mutation burden? Within the 400 and so patients treated on Nivo versus Ipi-Nivo studies, we had about 200 that were available, where there was tissue available for tumor mutation burden analysis. So this is a subset of the total population. And there was a fairly striking association, particularly in the tertile with the highest tumor mutation burden, for improved benefit, both on Nivolamab, as you see here, and particularly striking, I think, for the combination of Ipi and Nivo, with a response rate of 46%. This translates into improvement in progression-free survival, and again, I'll point out the tertile of highest mutation burden on Ipi-Nivo here, looking actually quite good, and overall survival as well. There's a relatively small number of patients on each arm in this Ipi-Nivo curve, starting with 25 to 27 patients, but really a one-year survival of 62%. These are previously treated metastatic small cell lung cancer patients, a really pretty striking result in my mind. And so these data, I think, are really encouraging and suggest not only that Nivolamab and Ipi-Nivo have activity in this disease, but we may actually have a way to enrich for those patients most likely to benefit. This has led to the relatively small data that I've just presented has led to a huge number of phase 3 trials that are going forward. I mean, the earth will be soaked with PD-L1 inhibitors here. So all of these are ongoing. 3 first-line phase 3 trials, all essentially the same platinum etoposide with or without Pembro, Atezo, or Durva. And in the case of AstraZeneca, they're also going to look at a 4-drug combination, platinum etoposide with Durva and Tremi as a third arm. All of these are ongoing, obviously no results yet, and in 2018, 2019, we'll actually either be having a really interesting discussion or a really depressing discussion. We'll see. Bristol Myers Squibb has taken a slightly different approach, looking at maintenance or second line as context for phase 3 trials. And again, these will report out sometime in the next year or two. I would point out, although this is a sort of clinical audience, I think there are real immunotherapy targets in small cell that may be distinct from PD-L1 and CTLA-4. These tumors tend to be infiltrated with macrophages, and we know from some of our mouse data, these are from some of our PDX models, that if we can target the macrophage don't eat me signals, we can get major responses in these models. This is also true for GEM models. And these tumors tend to lack MHC class 1, which is actually required for cytolytic T cell responses, but actually creates a sensitivity in these tumors to NK cell targeting. And I think there's a real opportunity here as well in thinking about drug development in small cell in IO, not looking at PD-L1 and CTLA-4, but looking at other targets that are particularly relevant for this disease. There's also been some recent interesting data looking at immunoconjugates in small cell lung cancer. I think the one that's generated the most interest here is a drug called rovat. This is an antibody drug conjugate with the antibody directed against a cell surface target called DLL3. It's a Notch ligand that's highly upregulated in small cell lung cancer. The antibody is linked to a toxic warhead. And the idea here is that the antibody binds to the cell surface. This gets internalized. There's cleavage of the linker and release of the warhead intracellularly, leading to tumor-specific delivery of this cytotoxic moiety. So DLL3 normally is not cell surface expressed. It gets aberrantly cell surface expressed in small cell lung cancer, in part because of the oncogenic pathway that is responsible for the development of small cell lung cancer and a particular transcription factor, ASCL1. I won't go through that data. But this drug has shown activity. It's also not a benign drug. It has substantial toxicities, and we're still sort of learning how to manage the toxicities of this antibody drug conjugate. These were data reported from the phase 1, but I think we're coming to the realization that the serosal effusions that are seen in this with this drug are problematic, and we really need better strategies for managing that. And we're still sort of working on that. This occurs in a fair fraction of patients and can be fairly persistent. Despite the toxicity, though, we do see activity. So this is a waterfall plot looking at response in patients with recurrent metastatic small cell lung cancer to this antibody-drug conjugate. A couple points here. One, we do see real responses, but I think more importantly, if we look at the patients in whom we had available tissue for looking at protein levels of the target, DLL3, you can see that only those patients who had high level expression of the target, that is over 50% positive in the blue, all of the responses are in that patient population. This suggests maybe for the first time we have a predictive biomarker for a drug in small cell lung cancer. That is, we could focus drug development on a patient population that's likely to benefit from the drug and avoid the toxicities that I talked about in the patients who are not likely to respond, who have low level expression of this target. This is the overall survival for the phase 1 study of this agent. Small numbers of patients, but now this has prompted multiple registration trials of this agent in recurrent small cell lung cancer. The 3 big ones are here. Trinity actually finished accrual in May of this year. That's a single-arm phase 2 trial in the third-line setting. That was designed in this way because there is no approved drug, actually third-line for small cell lung cancer. The Tahoe studies and the Miro studies are ongoing. These are more traditional phase 3s, randomized in the Tahoe against a standard of care topotecan and against placebo in the maintenance setting with Miro. These 2 trials are ongoing. Trinity we may hear about in 2018, the other 2 probably the following year. There's a trial that's actually combining these 2 strategies. So can you give ipilimumab, nivolumab, and rovat? My research staff calls this the nuclear option. I don't know whether it's going to be tolerable or not, quite honestly, but we're currently enrolling. That's all I can say about that at this point. And then a little snapshot of targeted therapies in small cell lung cancer. There are targets in small cell lung cancer, and actually there are multiple trials ongoing looking at these targets, and I think a number of them actually look sort of interesting. They're all relatively early, and we're still exploring how to best develop these as targets, but I think there are actually multiple ones that are interesting. I'll pick out just one, which are PARP inhibitors as a possibility. Lauren Byers at MD Anderson initially noted that PARP is highly overexpressed in small cells relative to non-small cells and suggested that this might be a relevant target for this disease. And indeed, single-agent studies of a potent PARP inhibitor, talazoparib, do show activity in small cell lung cancer. So these are data from a recently published solid tumor phase 1, but just pulling out the small cell patients, there are real responses here to single-agent PARP inhibitor therapy. And this has prompted a number of trials that are going on looking at various PARP inhibitors in the context of small cell lung cancer. We were interested in what could predict response to PARP inhibitors in the context of small cell lung cancer. From breast cancer and other diseases, we know that defects in homologous recombination, genes like BRCA1, BRCA2, are associated with high-level response to PARP inhibitors. Those basically don't occur in small cell lung cancer. So these are 160-some patients from Memorial Sloan Kettering with small cell lung cancer on whom we did genome profiling, looking at targets that are relevant for homologous repair deficiency, and really we don't see mutations in this context. There's also a way of reading out homologous repair deficiency by what are called HRD scores, no correlation in small cell. PARP itself as a target does not correlate with sensitivity to PARP inhibitors, but we do have a gene that actually does predict sensitivity to PARP inhibitors. It's a gene called SLFN11. It turns out to be a highly statistically significant predictor of PARP inhibitor sensitivity across many models of small cell lung cancer in the preclinical space, and I think is of interest going forward clinically. These are data that we, from a trial that we recently completed at Memorial Sloan Kettering together with MD Anderson and Hopkins, looking at recurrent small cell lung cancer patients treated with the DNA-damaging agent temozolomide with or without the PARP inhibitor veliparib in a randomized phase 2 trial. The addition of the PARP inhibitor was associated with a substantially increased response rate, as you see here. In the overall population, this did not translate into a progression-free or overall survival benefit. But in exploratory analysis performed by Lauren Byers at MD Anderson, if you look at the placebo control arm with temozolomide, on the left side of this slide, Schlafen-11 has really no predictive capacity for that drug. But if we look at the group of patients who got the PARP inhibitor, who got veliparib, you can see a clear separation of the curves, suggesting that the mouse data actually holds up in people, that Schlafen-11 expression is going to be a marker of sensitivity to PARP inhibitors in small cell. There are multiple other trials ongoing and recently completed in which this potential biomarker will be explored. But again, a targeted therapy that we think we have a predictive biomarker to enrich for activity in recurrent small cell. So to Corey's challenge, I think, the state of the state in small cell lung cancer, we are still using the same standard of care that we were using when Corey was in training, but there really are new targets. And I think, we're going to see some changes in this field in the next few years. I think there are a number of things that are looking quite promising. We're quite interested in this gene Schlafen-11. It actually not only predicts for PARP inhibitor sensitivity, but also for chemotherapy sensitivity. DLL3, I think, is an important target in small cell lung cancer. I talked about the ongoing antibody-drug conjugate trials. We actually like the target for developing other potential therapeutics as well. Immunotherapy is clearly going to play a role, I think, in this disease. There are a number of trials ongoing to look at immunotherapy together with chemotherapy, but I think we all have high hopes for immunotherapy in the context of recurrent disease based on the studies I presented. There are a number of other vulnerabilities that I think are currently of particular interest being studied in a variety of cancer centers, still, I would say, relatively early. And I think the data emerging on PARP inhibitors also looks promising for this disease. So, thank you.